get the patient's medical history, what's going on with them, you know, how this is different than normal for them, but also a big part of that is developing a relationship with the patient. Either developing, when I was working as a hospitalist, most of the people I saw I hadn't met before, so part of that is developing a relationship. When I worked in the office, it was kind of building on that relationship. Hey, you said, you know, that you were going to go on this vacation when I saw you 6 months ago. How'd that vacation go, or how's fishing, or whatever their favorite activity was, to spend some time talking with them about that a little bit. When you had paper charts, you know, in the office, you'd have this paper chart, and then we had a, you know, problem list and medication list, allergies, their, you know, family history, their past history, social history that was available there, and you would end up, you know, crossing this off or updating that or adding that, and so that was a lot of difference that way. When you're working in the hospital, that was also paper, and so you're seeing a patient in the hospital. Often we'd want to get their previous records and look at previous test results, previous history and physical, and kind of say, okay, rather than asking all these questions again, go over and say, I see you had your gallbladder out and you had this and that, and just confirm that information, rather than, because they get annoyed in the emergency room, they got asked all these questions, they get up to the floor, the nurses ask all these questions, I come in and ask all these questions, and so it's nice to, I need to make sure the information is accurate, but don't want to annoy them, if you will, at doing that over and over again. And with the paper chart here during the day, the unit secretary usually call medical records and say, hey, I need, you know, Joe's chart, and they get it together and bring it up to the floor. If, you know, on call at night, it was the nursing supervisor would go down and find their records, and there's always that delay of, you know, 15 minutes, a half hour till somebody could actually do that, because they had other stuff to do too. So that's the advantage of the electronic record, is you have that all there, and you certainly can, you know, again, you go through that information, make sure it's up to date. Did they develop any new allergies? Are they on any new medications that they weren't on when the last time, you know, they're done with their antibiotics they got 5 months ago, and so you update that information, but it's available both inpatient and outpatient, and that is a nice feature of, you know, you have it on your iPad, your laptop, whatever you happen to be using for records. So that's the history part. The physical part, there's not been a lot of change with that. It's still doing, you know, from my perspective as a physician, doing a physical exam. One of the docs I worked with, and I forget where that, who that was, but said you always want to touch the patient. And I think that is a important thing that sometimes we forget, that just the physical touch. And obviously you generally do that in an exam, but even if you don't necessarily need to do that, that's a good idea. Shaking hands is a simple way of doing that. I know there's some with the exam equipment, now they have stethoscopes where they have where it'll amplify the sounds, and so you can hear some of the heart sounds and things better. I think the other big change exam-wise is bedside ultrasound. And that's probably used most in the emergency room, where they have somebody that comes in and you can do a quick ultrasound. You know, is their heart pumping? Do they, you know, especially with a trauma, chest trauma patient, do they have, you know, the sac around their heart filled with blood and it's not pumping well? That you got to fix pretty quickly. Do they have blood around their lungs? Those types of things you can find out pretty quickly with that. The other thing we use that for now is putting in like central lines. We used to just, I guess, if you will, do that blind, is you find, you know, the landmarks and the anatomy, and this is where you slide the pretty decent sized needle in, and nowadays it's ultrasound guided, and so that makes that much safer because you can see, okay, this person's is a little deeper, this one's a little more shallow, so you can aim your central line. And safety, that's the other big factor with that. Laboratory-wise, a lot of the tests we do are new. I mean, just the complete blood count is a basic blood test that we do. When I worked in a lab before I went to medical school, and you would have a med tech look at a slide, and they would look at 100 white cells, and they would click, is this a neutrophil, is this a lymphocyte, is this a eosinophil, is this a basal cell, and they had a little clicker thing, and when they got through 100 cells, it would say it was this many. Then toward the end of my time working there, they had automated devices that would do that would just move around, identify cells, and then you would have a med tech look at that, double check them, and make sure, yes, it's being accurate. And I think that's the way it's done now. A lot of that is automated, and that chemistries, the basic sodium, potassium, calcium, liver tests, blood sugar, all of those have been around for a long time. I think now the advantage is a lot of the machines require less blood, and you get the results faster. The other thing with the electronic record is, as soon as it's done, it's put in the record, and it populates versus when I was a resident, the VA hospital was not known for being speedy with things. And so what we would do as a medical team is every afternoon, we'd go down to the lab and find our patients and write down their blood test results. We would go to X-ray, sit down with the X-ray resident and review the X-ray that was films, and then put that in, because the paper copy of the stuff would sometimes take a couple of days to get there. It's like, well, I need to know this to be able to take care of people today. So that part has changed. Yet there's lots of new things. A lot of the endocrine, thyroid, cortisone level, those types of things. Some of those were those were done like 2 or 3 times a week. And some of those were send-out tests, so you send them out and it would take a week or so to get the results back. Now, thyroid in particular, those are done every day, get the results back quickly. A lot of the other tests too there's still some that get sent out, but the more common ones, we get back a lot more quickly. The other thing, like hemoglobin A1C, which kind of measures what your average blood sugar has been over the last 3 months, that's a newer test, and that really has helped with diabetes management. Because one of the things is like, well, you have these 4 readings. If somebody was checking it 4 times a day, you have these, over the course of the month, you have this 120 readings, and say, well, are they doing okay? Are they not doing okay? Whereas this gives you a good average and can help do a better job with that, which is helpful for eliminating the complications of the vascular disease and things that go along with having diabetes. It's better if their diabetes is under better control. I mentioned X-rays. Initially it was plain X-rays, so they took an X-ray and they took it into the developing room, and they developed it just like you would, pictures back then. So there was this, gap between, okay, you took the X-rays and you get the films out probably half hour, 45 minutes later, because you have to go in a dark room and develop them. And then, you kind of, I remember taking films and kind of, if you angle them, that may give you a little better contrast if you're looking for specific things, or like you put in a central line, you take an X-ray, make sure it's in the right position, and sometimes it's like, well, is that kind of fool with it. Now with the digital, they take it, they have the picture there, and then there's all sorts of adjustments you can do on the contrast to be able to see specific things that you're looking for, which makes it very nice. And I mean, you can even view it on a laptop or iPad or that sort of thing, although usually you want to go to one of the bigger screens because bigger is better in that sense of being able to see things in more detail. Ultrasound, I mentioned that a little bit earlier. Diagnostic ultrasound, kind of initially in the early 80s, basically did that for pregnancies, pelvic ultrasounds, and then you did abdominal ultrasounds looking at the gallbladder and the liver. And that was pretty much all you did with ultrasound. As years have gone by, the resolution has gotten much better. You look at, well, we have a 6-month-old grandson, and so they had ultrasound pictures of Bruce, our grandson, when he's, you know, still pretty small. It's like, yeah, you can pick out fingers and toes and facial features and all sorts of things that you wouldn't have been able to do initially. And then the other thing now that's expanded to look at other, kidneys and vascular things are often looked at by ultrasound. The advantage is you're using sound waves, so there's no radiation to do that. You have to have a tech that is skilled at doing those things, and that was one of the things I enjoyed. Is a group of techs here were very good at that, and so, or they tell you it's like, yeah, this isn't quite good enough, you probably need to do something else to check this out. The other thing with ultrasound now is using that for diagnostic tests. So if somebody has fluid around their lungs, we used to just kind of tap, okay, the level's here, I'm gonna go down here and I'm gonna put in a catheter, thread it down and get some of that fluid off. Somebody that's got fluid in the abdomen, you'd kind of pick a spot and go in and hope you didn't hit anything important. And now it's done under ultrasound guidance, and so they look, okay, well, we'll have them shift a little this way so the intestines kind of move over, so we have this pocket where we can put the needle in, get the fluid out and do that safely. So that's another thing that has come. And also now ultrasound, we use that to guide like biopsies and things of various places, depending on where it is, that the ultrasound, and then they can place a biopsy needle and make sure they got this nodule or tumor or mass, and to get some material to find out, is it cancerous, non-cancerous, which is, again, you make sure you got what you're supposed to get and can determine that without having to open somebody up and get that in some cases. So those are factors that have been very helpful that way. CT, that's very commonly used now for lots of different things. Back in the early 80s, basically the only thing we did CT on was heads. We didn't CT anything else, but as time has gone on, they've improved the resolution and improved the ability to contrast between bone and soft tissue and things. Little vested interest. I had a friend of mine from high school that worked for GE Medical Systems that worked on CT scans. So we'd often talk about, what they're doing now and what they have coming up and things like that. So now basically you can CT anything from head to toe. You can get a lot of information both about, bony things, muscles, joints, tendons, nodules, internal organs, heart, lungs, intestines, liver, kidney, those types of things, vascular structures. They can do what we used to do, angiograms, where they inject dye. You can do that now with CT and look at the blood vessels going to the brain and things like that, and much higher resolution than it was before, and that too is used depending on the situation for biopsies. Is line up and say, okay, the needle's got to go this far, and then you scan again, make sure you're in the spot that you wanted to get, and do that. So that, particularly now in trauma, that's used a lot, because otherwise you do plain x-rays, and well, is that rib broken? Is that fluid around the lungs? Is that blood? That, you know, on the CT you can find that all out with one diagnostic test. Moving on to MRI, that was invented in the 80s. I don't think that was generally available, particularly in like smaller community hospitals. You may, you know, Milwaukee, Madison, Marshfield may have had MRIs in the 80s, but getting that to a community hospital, that was probably the 90s. The advantage of that is no radiation, but you have to go, it's a big magnet, so if you have a metal implant, then you can't use that. That obviously it's got to be non-magnetic, but if you have somebody with like titanium hip replacement, when you scan that area, you get this scattered light sort of thing, and you can't really look at that. So again, pluses and minuses. The other big thing with that is it's a very narrow tube, so people with claustrophobia have trouble with that. And sometimes if that's really the best test, sometimes we end up talking to our anesthesia colleagues about sedating somebody so you can get that scan. So that's kind of diagnostic stuff. Then the next thing is diagnosis. Well, diagnosing things is somewhat hasn't changed. In some ways it has changed. I think a lot of the common stuff we see, we know that regularly and take care of that. That's not an issue. However, with some more unusual things, sometimes it's one of those, yeah, I've heard of this, sounds familiar, but I can't quite think of what it is. So now you have, handheld things on your smartphone where you can put in the major symptoms, and it'll give you a list of differential diagnoses, and then there's a link that go to this one and you can read about that. No, that's not it, and the next one for more unusual stuff that it's in the past, it was either you go to the library in your office or your colleague's office, or you go downstairs to the library here and find the textbook and kind of page through that. It's nice to have that in your pocket. And then as far as treatment, lots more treatments that are available now than there were. I mean, there's a whole group of, you're looking at, especially immune modulating medications didn't exist very much back, in the early 80s, and now we have a whole bunch of these that are effective at treating different types of medical problems and are safer than a lot of the ones that we used to use. New categories of medications that I saw come, for blood pressure. We had 2 or 3 categories when I was a resident, and now we probably have 6 or 7 different categories of medication. So that makes a difference. If somebody doesn't tolerate something, it's like, okay, I have some other options, versus it's like, well, we're kind of limited. We don't have a lot of other things. And I think too, being able to do some things as an outpatient. You look at cancer patients and chemotherapy and things like that. You still have to do some of that as an inpatient, but when I first started, there was a whole cancer unit that somebody was getting their initial chemotherapy. They came into the hospital, stayed for a day or 2, and then went home, and now the vast majority of that is done as an outpatient, so that saves patients time and effort, and I think we'd all rather sleep in our own bed than in a hospital bed. And same thing with a lot of surgeries. You know, I look back at, well, when I was a kid, so this goes back farther than the 40 years. Grandma had cataract surgery, so she had this big eye patch on. She was in the hospital for 3 or 4 days, and now you come in, you know, in the morning and then go home that afternoon and then show up in the office the next day. And, you know, that has technology in a lot of ways. Things that are used to be inpatient can be outpatient. The other thing is a lot of the biopsies and things, again, some of that needle biopsy type stuff can be done as an outpatient versus, well, okay, you have to come in, we have to do a surgery and actually get in there and get that particular nodular mass to sort out what it is. And then in outpatient things too, laparoscopic surgeries allowed people to recover a lot faster. You know, gallbladder used to have a big, you know, 6-8 inch incision below the ribs here, and that would basically take care of people doing much of anything for 6 or 8 weeks, and now you got 4 or 5 puncture holes, and people recover faster. Now they still probably stay overnight in the hospital, but not 4 or 5 days like it used to be. So that laparoscopic has been a big advance in the surgical field. So yes, those were my thoughts as far as things that have changed. I don't know, questions, comments?
Yeah, so I'm curious about the role of hospitalists, how that evolved.
Okay.
And kind of where because you were in primary care?
Yes, I'm a family doctor by training.
So your own personal story about why you moved from primary care to hospitalist, but also go back to the history of how that evolved.
Okay, when I started practice, I did traditional family medicine where, you know, you went to usually came to the hospital in the morning if you had somebody in the inpatient, did rounds, and then went to the office, did office rounds, and then one of us was on call at night. So if somebody got admitted during the day, they would go in and, you know, see them that night and make sure that, you know, that all the things were ordered and taken care of for the patient. And I also did OB and delivery for, I don't know, probably 15, 20 years, something like that. So that was more, well, you got to come now. Then you'd do that. I would do that in the middle of the office, and you know, people understood that. It's like, well, if it's for me, he'll be doing the same thing for me. So gradually, as time went on, the volume of OB decreased, and a couple of the partners I worked with decided they didn't want to do OB anymore. Just some of that is middle of the night, so you end up coming in, and my smart comment was that I'd get here in 5 minutes, 10 minutes if I have to get dressed first. Now, I was not exactly following the speed limit to do that, but, you know, and sometimes if you knew somebody was close, it's like I'd just come here and they had a sleep room up there to, you know, I'd just hang out there, so I'd just have to walk across the hall if I needed to be there.
So I want you to continue with this, but did they not have OBGYNs then? Did you have to be credentialed in OBGYN?
Yeah, you have to be credentialed in OB in training. I did deliveries in training. There were 2 OBs that worked at the Manitowoc Clinic, so if you had somebody, it's like they're not progressing, they have certain things, you have the OB see them and decide, do they need a C-section or not, or this is something you can wait, and this is what I expect to happen. If this doesn't happen, then we need to do something else as far as their care and management. So
then when did the position of hospitalist begin to emerge? What caused that shift from?
I think the shift, again, this started, I believe, on the West Coast. And I think part of that was, okay, somebody got admitted at 10 o'clock in the morning, and if I'm in the office all day, I don't see them till 6 o'clock at night, And you call in verbal orders, but it's like you haven't really done a full exam on the patient, the emergency room physician typically did. And then you get there and it's like, well, okay, we could have done this and this and this during the day, but I didn't realize we needed to do that till I saw the patient. So that was part of there was the gap, and then the other change is payment, where they paid based on the DRG. So, the average stay for this is 3 days, so if they stayed longer, then your hospital is losing money. So that's the other thing I think that fueled that. I went to the National Hospitalist Conference. I'm thinking that's been going on like 25-ish years now, maybe a little more or less than that, but it was their 20th anniversary when I went to of having hospitalists as a specialty. And I think that's part of that, is just being able to see patients quickly and get them, taken care of and get things going, so you're not losing time that way. And in some ways it improves patient care in the sense of timeliness, but also then you're working as a hospitalist. I don't know, 95 or 98% of the people I saw, I didn't know. There are some that I had either taken care of before or my partners had taken care of, and so I knew of them because you'd see them, they came in and they twisted their ankle or whatever, and so that was part of that. So that's kind of a plus minus that way. So that's how the hospitalist system got started. The other thing that came in is walk-in care. That started kind of in the 80s, but got to be a major thing, I think, probably back in the 90s, where we used to leave probably about a third of our schedule open. We'd have scheduled patients, but you'd have, hey, I twisted my ankle, I have this sore throat, I have this cough for 4 days, acute care sorts of stuff, and we would just find a time slot and fit those people in. At some point, one of the docs I used to work with calls it the McDonald's mentality. They just wanted to walk in. Yeah. And so I'm not sure that's better or worse, but so we ended up then kind of modifying our practice, where we had usually one doc was, okay, you're the walk-in doc for that day, so you saw all the walk-in patients. Everybody else was all routine, physicals, follow-up appointments, that sort of thing. So their schedule was full, and I don't quite get it. If you're the sixth person that walked in 10 minutes, you're going to wait an hour, till everybody else is seen, unless you have some life-threatening illness, in which case we're probably going to call the ambulance and send you to the hospital. So that was one of the changes. How I ended up transitioning to hospitalist care is we used to have a hybrid program. So I would work as a hospitalist for 1 week, and the other 3 weeks I was in the office. And there were, 5 or 6 of us that did that, and Dr. Mike Hofteaser did that full time, but the rest of us would rotate in for a week, and then we'd have 3 weeks off, and so that's how the system worked. And then one of the docs that was a hybrid decided to retire, and it's like, well, we're not probably going to recruit somebody at that point. You're talking probably 10 years ago or so, that you were either going to work inpatient or outpatient. So they told those of us that were doing that, well, you have to kind of decide you want inpatient or outpatient. And now, for me, that was a difficult decision, because some of these people I've been taking care of for 20, 25 years, watched their kids grow up, watched, their family change, go through their family life, and got to know them and things. But part of it is my wife and I enjoy traveling, and the normal hospitalist schedule is a week on, a week off. So that kind of fit, and then my wife had retired. That's the other part of that. So she was now retired, so it's like, hey, why don't we go do something? So it's kind of, you know, one of the weeks we do all the stuff you're supposed to do at home, and then the other week we could travel if we wanted to do that. It was hard to say goodbye to the patients. I was very thankful. They were very gracious about that. And so that's how that, kind of my story, how I got to where I ended up. And then the last 15 months I worked half-time, because there was another doc that just wanted to work half-time, and so it's like, okay, we can, if you will, job share, and that's what I did toward the end. So then it was kind of one work 8 or 9 days a month. So, any other questions?
You mentioned in your earlier a whole lot of different advancements and changes, but if you had to pick out like maybe one or two things, if you were to say to a new doctor coming out of med school, this is something I'm really excited about for you, what it's going to be like for you in medicine today, what would you tell them?
My bias, and I'll admit it's a bias, is you still have to take a good history and do a good exam. I mean, there's testing that'll definitively diagnose things, and it kind of depends on what the presenting problem is. But if you take a good history and do a careful exam, what they say 80-85% of the time, you have a pretty good idea of what's going on with somebody. And then I think the other thing with that is if you listen to the patient, they're willing to listen to you. If they don't feel like they've been heard, you're going to need to work on that. And I think sometimes we get too enamored with tests. I mean, they're great. They've made things safer as far as, you know, doing biopsies and things where you don't have to open somebody up to get tissue, making procedures safer by avoiding hitting some important, you know, organs and things like that. But I don't know, it still goes back, I think, to history and physical. And again, that's developing that relationship with that patient. That will always pay dividends. Other questions?
So in medical school today, the focus on, is one of the residency possibilities being a hospitalist? Is that part of a rotation, or is that not part of the training?
That I'm not sure about that. Most hospitalists are either family doctors or internal medicine doctors. And I'm not sure now if they have a separate track. If you go into internal medicine, you decide, okay, I'm thinking more of being an outpatient doctor, therefore I'm going to do more of that, or if they still do that. I haven't kept up with that part of stuff. I don't have a reason to. And I think in family medicine, I think there's still probably the you know, inpatient rotations, outpatient clinic is part of that. I think, as I recall, first year we did 2 half-days a week as an outpatient, and then 3 half-days our second year, and 4 half-days the third year. So you had a fair amount of both inpatient and outpatient, and that fits. And sometimes, you know, rural areas, you may not have a hospitalist because you have a, you know, 10 or 15 bed hospital that. So healthcare is local, right? And how it is I remember one time we were out visiting Yellowstone, hearing about, well, if you need a referral, come, you know, a tertiary care referral, come to the Billings Clinic, which is like 250 miles away. But that was the nearest big referral center out west. Versus in Milwaukee, there's, you know, big hospitals all over the city. So it just depends. Good questions. Dan, you had one?
I was gonna ask about electronic medical record keeping. It seems to me that it's possible now to create tons and tons of information. Have we reached the point yet where it's difficult to manage that much information, or is it possible for a hospitalist to find what they need and not get lost in the weeds?
Well, that I think is one of the challenges of electronic records is, one phrase I heard is it's data rich and information poor. So sometimes you do have to kind of dig around to find the information that you need, and particularly looking at diagnosis, and this is my game plan for, somebody comes in with abdominal pain, I don't think it's anything big, we're gonna do this and this and this, but if it's not better, my next step would be to do this test or that test, and so if I happen to be gone and one of my colleagues see them, it's like, okay, can I find that okay, this is kind of what he was thinking about, this would be the next step, so they can care. Sometimes it is tough to kind of find that and understand what the thought process of my colleagues were. So that can be a challenge, because you print out some of the, a visit, and it's like 6 pages. And some of that is just, it's the medication list is, it's instead of this dose, this medication twice a day, it's, 5 lines, and it's not formatted in a succinct sort of way that you can find that. Other things. All right.
Well, thank you. That was
Thanks for
very
your attention.
informative, and appreciate all your years of serving here too.
Yeah.